Welcome to another episode of MDInsights. I'm delighted to be here today with Dr. Tolga Erim. Tolga is the Department Chair for Gastroenterology at Cleveland Clinic, Florida at our Weston campus. Tolga, thanks for making time to chat with me today.
Thank you for having me.
So you've obviously subspecialty interest within GI, and that's the field of advanced endoscopy. And we can talk about different perspectives on that. But Tolga, what led you to that within all of the various areas of GI that one might be drawn to?
Well, it's interesting you ask that because I really thought that I was going to be a primary care physician, one that does general practice in rural America, seeing kids and delivering babies and doing everything that a good primary care doctor does. And at one point in medical school, I spent some time with a gastroenterologist who was able to do many different things. He was able to see patients in a medical setting, and he was able to do procedures. He was able to sort of get that instant satisfaction from being able to help somebody with a procedure, and that's what started it all. And then after 9 years of post-medical school training, I ended up with advanced endoscopy.
Yeah, I think it is exciting, the concept of being able to do things instantly for patients and help them immediately with surgical or endoscopic or other procedures. The challenge for us sometimes, though, is the complications we can cause, and that might be something we discuss, but endoscopy now is helping us manage some of the complications that we can minimize but not completely bring to zero with surgical techniques. So tell us a little bit about your practice then within an advanced endoscopic field at a campus like Weston. What kind of things are you doing, and what kind of things are you seeing, and what areas do you think are changing?
Well, we are a referral center for not just Florida, but for South America, and some patients come across continents to see us from Europe, Africa. We have expertise in doing procedures that not many others do, and these are really centered around what I call organ-preserving procedures for example, tumors that grow on the surface of the intestinal tract that we can remove endoscopically, or doing procedures that used to be only done surgically through laparoscopic or open surgery in the past that we can do through the natural orifices, through the mouth or the anus. And this has been an evolution that I've been a part of. The field wasn't really where it is today when I first got started in this. It has the pioneering work was already done, but it was not being used commonplace, certainly not in our institution. And as time has gone on, this is becoming more and more widely accepted. The outcomes are becoming more and more reproducible, and patient satisfaction is very, very high. In fact, many patients will do their work on Google and come to see us in the office asking for the procedures that many of us think are not very well known, but it's out there certainly.
Yeah, absolutely. And I think from the patient's perspective, it's a complete paradigm shift from an operation that now obviously is increasingly laparoscopic rather than open, but you can transform it to where there's literally no incision, or at least no external incision. So tell us a little bit about some of the work you're doing with endoscopic removal of tumors.
Right. So, for example, just yesterday, we performed this procedure on 3 patients that came in with large polyps that were sent by surgeons, colorectal surgeons, who felt that it would be better to have these removed endoscopically rather than to try to remove a part of the colon. And we were able to successfully do this. These are techniques that are built on the traditional colonoscopy. And what we do now is we take our tools that we use for removing regular polyps and take it a few steps further by trying to create a submucosal space, that way decreasing the risk for bleeding, perforation, damage to the muscle layers of the intestinal wall, and shaving off these polyps and removing them sometimes in a single piece, what we call en bloc. And this way, when patients wake up, vast majority of the time, they don't have any discomfort. And I love that look on their face when they wake up, and the first thing they say when they wake up is, "Did you get it? Is it done?" And it's really wonderful to be able to say, "Yes, I think we got it out, and you're going to go home," rather than to need surgery for it.
Yeah, absolutely. And certainly in the colorectal space, EMR and ESD now increasingly are useful, and I think saving people from a segmental colectomy, which is good. What are your thoughts about endoscopic mucosal resection for piecemeal versus ESD for the larger polyps? It is nice when you can get it out on block, but there's some data around EMR that it's actually pretty good. And one of the challenges with all of this, of course, is well, two challenges. One is teaching it, and the other is trying to do it efficiently, because sometimes ESD can take a long time. And I think part of the question as we implement it in the future is how we can choose the right patients to use it for.
Absolutely, yes. It's for vast majority of the lesions we see, EMR is adequate. And ESD, it does give us an en bloc piece, but it does increase the risk for perforation. It does increase risk for certain complications. It's much safer to do in the rectum, where that risk of perforation is far more benign. But certainly in the right side of the colon, vast majority of the lesions that we see are able to be piecemealed by EMR. And even if there's recurrence, vast majority of the time, we can take care of that endoscopically. So in those cases where there is evidence that there is invasion into the deeper layers, ESD may not really be appropriate anyway. And so it's certainly technical expertise has a lot to do with it, choosing which way to go. And what we're concentrating on in the Cleveland Clinic Weston in Florida is teaching our colleagues in the region how to assess what is doable for an EMR, and then show them when we hold teaching sessions where they come in person and watch these procedures, how we do it and how to tackle challenges they may see is when they run into some scar tissue, for example, or a polyp that just won't fall into a snare. We have techniques that we can teach them that'll help with that.
Yeah, absolutely. And then also the nice thing is choosing the right ones to refer, because it's always easier to do them first time rather than when they're scarred and somebody had a crack at it and it stuck down to the muscularis. It's easier first time. What about the upper endoscopy and tumors and Lyomyomas and full thickness resections and other things?
So this again goes back to this innovation about discovering the submucosal space, and this has been the biggest revolutionary finding for us in endoscopy, because what we've discovered is that even though the intestinal wall or the esophagus wall or the gastric wall is only a few millimeters deep, there is a space between the very top layer, you can consider the skin of the GI tract, and then the bottom layer, the muscle layer, that we can expand. We can expand multiple fold, in fact, so much so that we can insert the entire endoscope into it. And then we dissect along this plane, and we can do procedures like endoscopic myotomy of the esophageal wall for treatment of achalasia. We can do a procedure called pyloromyotomy, endoscopic peroral pyloromyotomy for treatment of gastroparesis. And we can, while we're in that space, we can also resect tumors that are growing in the muscle layer, either the muscularis propria or the more superficial muscular layer that we've termed now STIR, submucosal tunneling endoscopic resection. And these are, again, I put these in the subheading of organ preserving procedures, because then we don't have to resect the esophagus wall. We don't have to resect the gastric wall. And even if we do end up doing a full thickness resection, we've created a tunnel that is our safety net for not causing a perforation.
Yeah. Again, it's transforming approaches and outcomes. Now, I know that you've put a lot of effort into doing it in a very collaborative fashion, and it's been an advanced endoscopic surgery and advanced endoscopic GI practice. Maybe you'd talk a little bit about that partnership and what you think its role is in different centers and moving forward.
Absolutely. I think that this team approach is what sets us apart more than anything else from other institutions. It's we don't necessarily have my department, your department. We just work collaboratively to achieve whatever end that we're looking for. So the person who set us off on this and who's been our guru is Jeff Ponsky, who's an outstanding endoscopist and also a surgeon who has taught probably hundreds of people in the past. But when he came down here to Florida, he's the one that really set us on the course, and we've been doing our best to keep it going. Working with a surgeon when you're a gastroenterologist endoscopist, it can really be revelatory. I mean, you gain a different understanding of this space that you're dealing with, of the muscle layer, of the vasculature, of what to do when you run into difficult situations, what not to be afraid of, and if you are going to run into a complication, how to deal with it. It is. I wish that every gastroenterologist, advanced endoscopist, had a chance to actually team up with a surgeon and work through difficulties. I think it puts you on a different level.
Yeah, I think we get, partly training, partly practice. We get a very different perspective on the GI tract, largely, not always, because we do a lot of endoscopy too, but coming to it from the outside. So we know the vessels, we know the nodes, we know the planes, we know everything else. And so that's why when you have these collaborative partnerships, we to gastroenterologists who are evolving into that space can kind of give that, part of it I think is psychological support, knowing it's safe.
Yes.
And part of it is understanding of the different planes of anatomy, and then you guys often have the endoscopic volume or whatever. So moving forward in education, though, it becomes a challenge because not many centers have that kind of collaboration. And then I think also not many centers have a high enough volume of some of these really complex subspecialty procedures. So how do we manage that moving forward?
I think it's going to take a leap of faith from both sides. And every once in a while, I'll see a tweet going out saying how, gastroenterologists who do colonoscopy have better rates than surgeons who do it, or non-gastroenterologists, so forth. And I think that I really try not to participate in this because I think it's just, you have to understand the playing field for what it is. There are different perspectives. You need to be able to use both. And if you're going to have a team approach, you really need to start to work at breaking the barriers down. Part of it is that I think that when we're in our subspecialty societies, we sort of get into our camps as well. I think that moving in the future, I think it would be great if the societies started to become more collaborative themselves, instead of just having gastroenterologists in one society and predominantly surgeons in another society. I hope that we can kind of get that back together. Once that happens, I think individual institutions are going to find it easier to do, and instead of just carving out space and being territorial about it, to start working. Our model of compensation and financial models, they're really perfect for that. We can have a collaborative relationship without feeling like we're encroaching on each other's areas. Maybe that is the model that others will start to adapt in the future as well.
Yeah, I think it's partly that. It's partly culture as well, a culture of collaboration and multidisciplinary care, and it's partly the institute model where the departments are much more merged than in many other places. But I think you're right. It's an adjustment we have to come to as gastroenterologists and as GI surgeons, whatever area of the GI tract we're in nationally. Because when you look nationally at how care is provided, obviously gastroenterologists do a lot of volume, but that's particularly city-based and suburb-based rather than nationally, where it's not even colorectal surgeons for lower GI. It's a lot of general surgeons are doing it and doing a lot of the endoscopy and colonoscopy and providing a service. So, I think part of it as well is, yes, it's a leap of faith, but it shouldn't be a leap of skill sets because, just because you're doing screening colonoscopies doesn't necessarily mean you can do some of these complex ESDs or transmural procedures. And it really has to be a partnership moving forward if we're going to keep it safe for patients, which is what it's all about at the end of the day. Yeah, it's going to be an interesting space to watch.
That's what really drew me to it to begin with, is that doing rotations in medical school, I was seeing that it wasn't so much about what is going to be the next surgery that's going to be the next step, but how are we going to transcend all of this? And I think that that's what really drew me to doing endoscopy, is that there's that potential for going to that next level in my lifetime, at least.
Yeah, well, drew you to it, and now you're helping evolve the field. So, Tolga, thanks very much for all you're doing, and thanks for spending time with me today on MDInsights, and I look forward to seeing everybody for our next episode. Thanks again, Tolga.
Thank you. I'm delighted. Thank you for having me.